Okay, so I need you to sit with me for a second, because I've been going through case after case of this, and there's a pattern that keeps showing up that almost nobody is talking about. A girl keeps rubbing her eyes at the dinner table. Her mother tells her to stop touching her face. A teacher sends home a note saying she seems distracted in class, maybe she needs glasses. Her father notices she asks for water constantly, more than any of his other kids ever did, and he jokes that she must be part camel. Nobody in that house thinks anything is wrong. These are just things kids do. Every parent watching this has had a version of that exact evening, and that's exactly why this disease gets away with hiding for so long. Then one night she says her jaw hurts when she chews, and there's a swelling right along the line of her ear that wasn't there yesterday. The pediatrician looks at it and says one word that sends a small jolt of worry through the room. Mumps? But the vaccine records say that shouldn't be possible. Blood work comes back. It isn't mumps at all. It's Sjogren Syndrome. A disease most people have only ever heard of, if at all, as something that happens to women in their 50s and 60s. Not something that happens to an 8-year-old girl who still sleeps with a nightlight on. I want to be honest with you about why I'm making this video the way I'm making it. I'm not going to lecture you from behind a clipboard. I'm going to walk you through this the way I'd walk a friend through it if her daughter was showing me a strange list of symptoms and asking me if she should be worried. Piece by piece. Clue by clue. Because that's really what this is, a case that gets solved by noticing a pattern most people are never taught to look for. Here's what almost nobody is told. Sjogren's syndrome can begin in childhood. It's uncommon, but it's real, and when it shows up in a child, it very often looks nothing like the disease adults get diagnosed with. That mismatch between what parents expect the disease to look like and what it actually looks like in a young body is what we are calling the sicker gap. It's the space between the textbook symptoms doctors are trained to look for and the quieter, stranger symptoms a child actually shows up with. Falling into that gap is how years pass before anyone puts the pieces together. By the end of this video you'll know the early warning signs that tend to get dismissed as ordinary childhood stuff, why girls are affected far more than boys, why this disease is such a master of disguise in young bodies, and when a pattern of symptoms is worth bringing to a doctor. Stay with me, because there's a symptom coming up that almost never gets connected back to the immune system at all, and once you hear it, you won't be able to unhear it. Part 1. Opening the case file. Before I continue, I built something specifically not for just tracking and doctor's appointment. It is called Sjogren's Ultimate Symptom Map and Diagnostic Action Plan, and it walks you through exactly which symptoms to track not just for Sjogren but also for MS and RI. Drop symptom map in the comment, and I would send the link for you to access it. Let's start with what we are actually dealing with, because you can't investigate something you don't understand. Sjogren syndrome is an autoimmune condition. In plain terms, that means the immune system, which is supposed to protect the body from outside invaders like viruses and bacteria, gets its wires crossed and starts attacking the body's own tissue instead. In Sjogren's, the primary targets are the glands that produce moisture, especially the salivary glands that make saliva and the lacrimal glands that make tears. Over time, that immune attack can reduce how much moisture those glands are able to produce. Now here's where the investigation gets interesting. In adults, this usually shows up as a slow, steady dryness. Dry eyes. Dry mouth. It can take years to become obvious enough to investigate, but at least when it finally does, it looks like what the textbooks describe. In children, the picture is almost flipped upside down, and this is the detail that trips up even experienced doctors. Kids more frequently present with inflammation and swelling before they ever complain of dryness, if they complain of dryness at all. The parotid glands, the salivary glands located just in front of the ears, can swell up in sudden episodes that come and go, which is exactly why it gets mistaken for mumps so often. A child's body also tends to produce more systemic, whole-body symptoms early on, like fatigue and joint pain, rather than the localized dryness adults report first. So if you're a parent sitting there thinking, well, my daughter never complains her eyes are dry, so this can't be it, I want you to hold that thought, because that's the exact trap this disease sets. Why girls? This is one of the questions I get asked the most, and the honest answer is that researchers are still piecing it together. Girls are affected far more often than boys, in children just as in adults, and the leading theories point to a combination of hormonal factors and genetic predisposition that make female immune systems statistically more prone to this kind of misdirected attack. The full biological picture is still being studied, and there isn't a single clean answer yet. What matters more for you, sitting here as a parent, is simpler than the biology. If a daughter is showing a strange cluster of symptoms that don't add up to any single obvious explanation, Sjogren's deserves to be somewhere on the list of possibilities, even though it's rare. And here's the part that keeps this particular case difficult to crack. Because the symptoms are so unusual in kids, and because the disease is so rare in this age group to begin with, it is frequently misdiagnosed, or explained away for years. A rash gets treated as eczema. A fever gets treated as a virus that never quite resolves. A cavity gets treated as bad luck. Nobody is doing anything wrong exactly, they're just working with incomplete information, because nobody taught them to connect these dots. That's the whole reason this video exists. Comment below if you or someone you know has gone through a long, frustrating search for an autoimmune diagnosis. You are far from the only one, and this comment section has quietly become a place where a lot of families have found each other and compared notes on exactly this kind of thing. Part 2. The evidence. Sjogren's looks very different in girls and children than it does in adults. Adults tend to present first with severe dry eyes and a dry mouth. Girls and teenage girls are far more likely to show something else entirely first: recurrent swelling of the salivary glands, extreme fatigue, and joint pain, while the classic dryness stays mild or is barely noticeable at all. That's exactly why recognizing Sjogren's in a young girl means watching for a specific combination of systemic symptoms, glandular symptoms, and a few gynecological signs almost nobody talks about. According to pediatric guidelines from groups like the Sjogrens Foundation, missing these early markers is one of the biggest reasons essential care gets delayed for years. Let's go through the evidence category by category, the way you'd lay out clues on a board and start drawing lines between them. The first category is the swollen glands and facial changes, because this is usually the first thing a parent actually notices, the first clue that makes it into the file. It's sometimes called chipmunk cheeks, a visible, recurrent swelling in the parotid salivary glands, the ones located right along the jawline just in front of the ears. It comes and goes, and it is mistaken for mumps or a routine dental infection more often than almost any other symptom on this list. Think about how many parents have looked at that swelling, thought mumps, checked the vaccine record, seen it's up to date, and just quietly filed the whole thing under unexplained and moved on. That's a missed clue right there. The jaw area can feel painful or tight, especially during a flare or while eating, which is usually what finally sends a family to the doctor in the first place. Next comes the pain and whole body symptoms, the ones that rarely get connected to an immune problem at all, because on their own they sound like 100 other ordinary childhood complaints. Profound fatigue is common, a severe, uncharacteristic exhaustion that doesn't improve no matter how much a girl sleeps. I want you to really sit with that word, uncharacteristic. Not the normal tired of a kid who stayed up too late. The kind of tired where a normally energetic child suddenly can't get through a school day without needing to lie down. Joint and muscle stiffness shows up too, chronic aches, swelling, or tenderness in the fingers, wrists, or knees that often gets waved off as growing pains, because growing pains are such a convenient, harmless-sounding explanation that almost every parent reaches for it without thinking twice. And then there are the unexplained fevers, frequent, low-grade fevers or night sweats with no viral cause anyone can ever pin down. This is the one that surprises almost every parent I talk to, because a recurring low fever almost never gets mentally filed under autoimmune disease. It gets filed under, she's probably fighting off something, and the case goes cold before it even opens. Then there's a category that's easy to miss precisely because it doesn't look like dryness at all, what we are calling mild glandular dryness, and this is where the investigation really has to slow down. Instead of complaining that her eyes are dry, a young girl is far more likely to rub her eyes constantly, describe a sandy or gritty feeling, react strongly to light, or struggle to tolerate contact lenses. If you've ever caught your daughter rubbing her eyes and assumed it was allergies or screen time, you are absolutely not alone. That's the single most common misread in this entire list. The mouth tells its own quiet story too: rapid, unexpected tooth decay, frequent cavities, or mouth sores despite excellent brushing habits. Think about how strange that actually is when you say it out loud. A kid who brushes twice a day, flosses, eats reasonably well, and somehow keeps showing up at the dentist with new cavities every visit. That's not bad luck, that's a clue. Some girls need to sip water constantly just to get through dry foods like crackers, or mention that food tastes different than it used to. And chronic dry nasal passages can lead to frequent nosebleeds, scabbing, and recurrent bleeding that seems to come out of nowhere, the kind that gets blamed on dry winter air year after year even when it happens in the middle of summer. The fourth category is the one that's most overlooked of all, and it deserves to be said gently, honestly, and without a hint of embarrassment, because the embarrassment is exactly what keeps it hidden. Roughly 5% of girls with Sjogren's experience vulvar or vaginal itching, burning, and irritation. Because of how uncomfortable this is to talk about, this symptom is heavily underreported in adolescence, and it's one of the least likely to ever be mentioned out loud, by the child or by the parent. If your daughter has ever mentioned discomfort like this, even once, even quietly, I want you to actually write it down. Not because it's dramatic, but because in an investigation, the evidence nobody wants to talk about is usually the evidence that matters most. Skin can carry its own signs too, circular red patterns known as annular erythema, small purple spots called purpura, or skin that has simply become unusually dry and itchy in a way that doesn't respond to the usual lotions. Finally, there are the neurological and internal markers, the clues that live furthest from what anyone thinks of as a gland problem. Brain fog can show up as a sudden difficulty concentrating at school, memory lapses, or uncharacteristic trouble thinking clearly, something teachers often notice before parents do, which is why that note home about being distracted deserves a second look instead of a quick dismissal. Nerve tingling can bring burning, numbness, or a pins and needles sensation in the hands or feet, easy to miss because kids rarely have the vocabulary to describe it accurately. And digestive changes, persistent acid reflux, heartburn, or general stomach upset, round out the picture, often treated as a sensitive stomach for years before anyone asks what else is going on. Here's the thing I really need you to take away from this section. Individually, every single one of these looks harmless. A rash, a cavity, a tired kid, a low fever. That's exactly what makes this disease such a good investigator itself. In a way, it hides in plain sight by scattering its clues across completely different parts of the body so that no single doctor ever sees the whole picture at once. It's the combination, and the persistence, of several of these symptoms together that matters far more than any one of them on its own. One tired week means nothing. A tired kid with unexplained fevers, a swollen jaw, and constant cavities means it's time to start connecting the dots out loud, with a doctor, on paper. The lookalikes. Before we get to why this case is so hard to close, I want to walk you through the other suspects, because part of being a good investigator is knowing who else could plausibly be responsible for the same evidence. This is exactly what makes Sjogren's such a slippery diagnosis in a young girl, because almost every symptom on our list has a far more common explanation sitting right next to it. Take the swollen jaw. The obvious suspects are mumps, a dental abscess, or a swollen lymph node from a garden variety infection. All three are dramatically more common than Sjogren's, which is exactly why doctors reach for them first, and honestly, they're usually right too. The tired, achy joints point straight at juvenile idiopathic arthritis, a completely different autoimmune condition that shares some features with Sjogren's but is treated differently. The eye rubbing and light sensitivity point at seasonal allergies or too much screen time, both far more likely explanations for the average kid walking into a pediatrician's office. The unexplained fevers point at a slow-clearing virus, something that's going around at school, or even just a string of bad luck with the seasonal bugs going through a classroom. None of these lookalikes are wrong to consider. That's the whole point. A good doctor rules out the common explanations first, because ruling out common things first is usually the right call. The problem only shows up when none of the common explanations quite fit, when the fevers keep recurring after the virus should have cleared, when the joint pain doesn't respond the way juvenile arthritis typically does, when the allergy medication doesn't touch the eye irritation at all. That's the moment the investigation needs to widen. That's the moment Sjogren's needs to at least enter the conversation, even if it turns out not to be the answer. The emotional side nobody talks about. I want to slow down for a second, because I don't think enough of these videos talk about what this actually feels like from inside the house while it's happening, and I think that matters just as much as the medical facts. If you're a parent who has been going back and forth to doctors for months or years without an answer, you have probably, at some point, wondered if you're overreacting. You've probably had a moment where you thought, maybe I'm just an anxious parent, maybe she really is just tired, maybe I'm the one making this bigger than it is. I want to tell you clearly, that instinct that something doesn't add up is not something to talk yourself out of. Parents are usually the first ones to notice a pattern precisely because they're the only ones watching the whole picture, every day, across every context, in a way no single doctor's appointment ever captures. And if you're watching this as someone a little older, someone who went through exactly this as a kid and is only now, as an adult, hearing a description that finally matches what you went through, I see you too. A lot of adults with Sjogren spent their childhood being told they were dramatic, or dehydrated, or just needed to try harder in school when the brain fog hit. That's not a small thing to carry. If any of this is landing for you personally rather than as a parent, that's worth a conversation with your own doctor too. For the kids in the middle of this, the ones actually living inside these symptoms, there's a quieter cost that's easy to miss. Kids who are constantly told their pain isn't that bad, or that they are just tired, or that they need to stop making excuses, start to distrust their own bodies. They stop mentioning symptoms because mentioning them hasn't helped before. That's part of why an actual diagnosis, even one with no cure, tends to be such a relief for families. It's not just an answer. It's permission for a child to trust what she's been feeling all along. Part 3. Why the case goes cold. If you're wondering why it takes families so long to get an answer, you're asking exactly the right question, and the honest answer is that this disease is genuinely difficult to pin down, even for good doctors who are paying close attention. Every symptom on that list overlaps with something more common. Allergies. Dehydration. A viral illness that's just taking a while to fully clear. Normal childhood growing pains. Even other autoimmune conditions that share similar features and get considered first simply because they are more common in kids. That overlap is the core of the sicker gap, and it's why diagnosis can take a long time, sometimes years, and sometimes several different doctors, before anyone connects the dots. Think about how a typical case actually unfolds. A pediatrician sees the swollen glands and thinks mumps or a dental abscess. A dentist sees the cavities and thinks the child needs better brushing habits. An allergist sees the eye rubbing and the light sensitivity and thinks seasonal allergies. A general practitioner sees the fatigue and figures it's a growth spurt or just a phase. Every single one of those doctors is being reasonable with the information directly in front of them. Nobody is failing anyone on purpose. The problem is that nobody in that chain has the full case file, because the file lives scattered across a pediatrician's notes, a dentist's chart, an allergist's intake form, and a parent's private worry that never quite gets said out loud in full. When Sjogren's is suspected, specialists typically use a combination of tools to investigate, and knowing what these are ahead of time can help you feel less lost if you ever end up in one of these appointments. Blood work can look for specific antibodies and markers of inflammation associated with autoimmune activity, essentially checking whether the immune system's fingerprints are showing up where they shouldn't be. Eye testing can measure how much tear production a child actually has and check for any resulting damage to the surface of the eye, even in kids who never once described their eyes as feeling dry. An evaluation of the salivary glands, sometimes including imaging or a small tissue sample, can check for the kind of inflammation characteristic of this disease, essentially confirming whether that recurring swelling really is what the pattern suggests it is. According to pediatric guidance from organizations that specialize in this condition, catching these patterns earlier gives families a real head start on managing symptoms before they progress further. None of this means you should try to diagnose your own child from a video on the internet, and I want to be really clear about that. What it does mean is that walking into a pediatrician's office with a written list of specific, persistent symptoms, rather than a vague sense that something feels off, dramatically improves the odds of getting taken seriously and referred to the right specialist sooner. Doctors respond to patterns. Give them the pattern. To make this less abstract, let me walk you through what a typical timeline looks like, pieced together from the kinds of patterns families describe again and again. This isn't any one real child, it's a composite of the shape this journey tends to take, but you'll probably recognize pieces of it. Year 1, the swelling shows up for the first time. It's treated as mumps, then as a dental issue when the vaccine record rules mumps out. It resolves on its own after a couple of weeks, the way these flares often do, and everyone moves on, relieved. Later that same year, the fatigue starts becoming a pattern instead of an occasional thing. It gets attributed to a growth spurt, or a demanding school year, or simply being a teenager. Nobody connects it to the swelling from a few months earlier, because on paper, there's no reason to. The following year, the cavities start piling up despite good brushing habits, and around the same time, the eye rubbing becomes frequent enough that an allergist gets involved. Eye drops help a little. Not completely, but enough that everyone assumes it's working. Somewhere in there, the joint pain starts, dismissed as growing pains, and a low fever starts recurring every few weeks with no clear cause, dismissed as whatever's going around. Each of these gets its own explanation, from its own specialist, at its own separate appointment, and not one of those specialists ever sees the other pieces. It's usually only when a parent sits down, frustrated, and writes every single symptom on one page, in one place, for the first time, that the pattern becomes visible enough for a doctor to actually see it too. That's the moment the case usually starts moving again. That one page is often the single most useful piece of evidence in the entire file. Building your own case file. This is the part one wish more videos actually covered, because knowing the symptoms is only half the job. The other half is knowing what to do with that knowledge, and this is where you get to act less like a worried parent hoping someone else notices, and more like the investigator who cracks the case. Start a simple symptom timeline. Nothing complicated, just a running note on your phone. The date the jaw first swelled. The date the fever started showing up. How many cavities at the last 2 dental visits, compared to the visit before that? Whether the fatigue is a daily thing or something that comes in waves. Doctors are trained to notice patterns, but they can only notice the pattern you actually hand them. A parent who says my daughter has been tired lately gets a very different response than a parent who says my daughter has had unexplained fevers 11 times in the last 4 months, recurring jaw swelling twice, and 3 new cavities since her last cleaning despite no change in her brushing habits. The second version gets taken seriously immediately, because it sounds like exactly what it is, evidence. Bring up more than one symptom at once, even if they seem unrelated. This is genuinely one of the biggest reasons cases like this get missed for so long. A parent mentions the eye rubbing at one visit, and 6 months later mentions the joint pain at a completely separate visit, and neither doctor ever hears about both at the same time. If you notice a cluster forming, even a loose one, say all of it out loud in the same appointment, even the symptom that feels a little embarrassing to bring up, even the vaginal irritation, even the brain fog that you've been quietly blaming on her phone. Ask directly whether autoimmune causes have been considered. You are allowed to ask this. You are allowed to say the word Sjogrens out loud in an appointment, even if you're not sure you're pronouncing it right. Doctors are not offended by an informed parent, most of them genuinely appreciate it, because it means they're not starting the investigation from zero. And if the first doctor doesn't find an answer, that doesn't mean there isn't one. It might just mean this particular case needed a specialist, like a pediatric rheumatologist, someone whose entire job is looking at exactly these kinds of scattered, crossbody clues. What a specialist visit actually looks like. If you've never sat in a pediatric rheumatologist's office, the idea of it can feel intimidating, like you're walking into something much bigger and scarier than it actually is. I want to demystify that a little, because knowing what to expect tends to take a lot of the fear out of it. Usually, the visit starts with a long conversation, longer than a typical pediatrician appointment, where the specialist asks about the full timeline, every symptom, when it started, how often it happens, and what makes it better or worse. This is exactly why that written case file you've been building matters so much, because it turns a vague, overwhelming conversation into a clear, organized one. From there, a physical exam checks things like the salivary glands, the joints, and the skin for the specific signs associated with autoimmune activity. Blood work usually follows, sometimes on the same day, sometimes as a follow-up, checking for the antibodies and inflammation markers we talked about earlier. Depending on what shows up, there may be a referral to ophthalmology for detailed eye testing, or a referral for a salivary gland evaluation. None of this happens in a single afternoon, and that's normal, not a sign that something has gone wrong. A real diagnosis is built the same way any real investigation is built, one piece of evidence at a time, cross-checked against everything else in the file, until a clear picture finally forms. It can feel slow while you're in it. It tends to feel worth it once you're on the other side of it, holding an actual answer instead of another guess. Part 4. Treatment and living well. There is currently no cure for Sjogren Syndrome. I'm going to say that plainly, without softening it and without making it sound scarier than it is either, because you deserve the truth, not a sales pitch. What is also true, and this matters just as much, is that with proper management, many children do well and are able to live active, full, normal lives. A diagnosis is not a life sentence of feeling terrible. For most families, it's the moment things finally start getting better, because for the first time, everyone is treating the right thing instead of chasing a dozen separate symptoms with a dozen separate explanations. Management usually centers on relieving the specific symptoms a child is experiencing, and it tends to look less dramatic than people expect once it's actually underway. Artificial tears or eye lubrication for dryness and irritation. Good oral care and regular dental monitoring to protect against the cavities this condition makes more likely, often meaning more frequent cleanings rather than anything drastic. Consistent hydration throughout the day, which sounds simple but genuinely helps with several symptoms at once. In some cases, medications prescribed by a specialist to help manage inflammation or specific complications, tailored to whatever that particular child's pattern of symptoms looks like. And ongoing monitoring over time, since autoimmune conditions can shift and evolve as a child grows, which is exactly why that follow-up care matters so much. Beyond medical treatment, general healthy habits, consistent sleep, balanced nutrition, and regular follow-up appointments all play a supporting role in how well a child manages this condition long-term. If there's one single protective habit that matters more than any other, it's staying consistent with follow-up care rather than treating an initial diagnosis as the finish line. It isn't the finish line. It's the start of finally having the right map. There's also a daily life side of this that doesn't get talked about enough. A child managing fatigue and joint pain may need some flexibility at school, extra water breaks, permission to step out and rest, or accommodations around gym class on flare days. This isn't about treating her differently for no reason, it's about giving her body the room it actually needs. Teachers who understand what's going on tend to become allies rather than obstacles, which is part of why it can help to have a simple, calm explanation ready to share with a school nurse or homeroom teacher once a diagnosis is confirmed. It's also worth saying that flares tend to ebb and flow rather than stay constant. A child might have weeks where she feels almost entirely like herself, followed by a stretch where the fatigue or joint pain flares back up, sometimes with a clear trigger like an illness or a stressful stretch at school, and sometimes with no obvious trigger at all. Knowing that pattern exists in advance tends to make the hard weeks feel less alarming, because you'll recognize them for what they are instead of feeling like you're back at square one every time. A quick myth check before we close. I want to clear up a couple of things quickly, because misinformation spreads faster than facts, and I don't want you walking away from this more scared than informed. Myth 1, only older women get Sjogrens. Not true. It's less common in children, but it happens, and it's exactly why this video exists. Myth 2, if her eyes and mouth aren't dry, it can't be Sjogrens. Also not true, and honestly the most dangerous myth on this list, because we've spent this entire video showing you exactly why dryness is often the last symptom to show up in a young girl, not the first. Myth 3, a diagnosis means a lifetime of severe symptoms. Not necessarily true. Many children manage this well with the right care, and severity varies enormously from case to case. Myth 4, if the pediatrician didn't mention it, it must not be worth considering. Not true either, and honestly the most important myth to let go of. Pediatricians are excellent generalists managing an enormous range of possible conditions in every single appointment, and rare presentations in children are, by definition, rarely the first thing that comes to mind. That's not a failure on anyone's part. It's simply why bringing a clear, organized pattern of symptoms into the room, and asking direct questions, matters as much as it does. If there's one thing to take from this video, it's this. Sjogren Syndrome in a child rarely announces itself the way people expect it to. It doesn't always come with dry eyes and dry mouth the way it does in adults. It comes disguised as growing pains, as allergies, as a picky eater, as a distracted student, as mumps that never quite adds up. It hides in the gap between what we expect a disease to look like and what it actually looks like in a young, still developing body, and it takes a certain kind of stubborn attention to catch it before it's had years to hide. You don't need to walk away from this feeling alarmed. Most children with symptoms like these will never have Sjogrens. But if several of these signs are showing up together and persisting, it's worth a real conversation with a pediatrician, not a guess typed into a search bar at midnight and then closed out of guilt or fear. And if you want more evidence-based videos that help families catch important health warning signs early, before the case has had time to go cold, subscribe. This channel exists for exactly this reason, to hand parents the pattern before it takes years to see on its own. One last thing before you go. If you've made it this far and you're recognizing pieces of your own daughter, or your own childhood, in what we just walked through, take a breath. Noticing the pattern is the hard part, and you've already done it. The next step is smaller than it feels right now. One appointment, one written page, one honest conversation with a doctor who's finally getting the whole file instead of a scattered piece of it.